make sure that that is working. And we are recording. Okay. Hello, everyone. Welcome. My name is Jill Johnson, and I am the Executive Director for the International Society for Quality of Life Studies, ISQOLS. And we are pleased today to have Dr. Rima Algarni from Saudi Arabia, who is here to present her webinar on her research that she actually did present at the ISQOLS conference in Granada in September. And the title of her presentation is Exploring the Concept of Health-Related Quality of Life for Patients on haemodialysis. Did I say that right?
That's all right.
In Saudi Arabia. So before we get started, just to reiterate that this is part of the International Society for Quality of Life Studies. And we are pleased to help our members present their research. So if you're watching this and you are a member, a current member, and you would like to present your research in this format, please contact us at office@isqols.org and we'll be happy to set that up. So on that note, I'm going to go ahead and give the controls over to Dr. Algarni and make sure that she is set up, and then she will go ahead and get started. So
thank you.
You are welcome.
Okay, so do I have the control now?
Yes, you do.
Well, let me put it on the, yes. So I'm going to talk about my PhD project, which is about exploring the concept of health-related quality of life for patients on hemodialysis in Saudi Arabia. And I will be talking particularly about the research and the methodology that I conducted and the key findings and results of the study. Just to start talking about this study, let's talk about the concept of quality of life. Actually, it's an old concept that was approached since ancient days. It was adopted by different disciplines such as sociology, psychology, and recently by the health discipline, where it is added to the health-related quality of life, and it is named and related to health. This concept is highly subjective as viewed by patients and people rather than the healthcare provider. And this is proved by so many literature. It has different meanings for different people in different places, and it has different meanings as well for the same person as at different times. So it could mean something for me today, but tomorrow we don't know what happens and what circumstances that I will be living in, and the whole concept of quality of life will differ to me. Throughout the literature, we will find that there is a worldwide consensus that the health-related quality of life of patients with end-stage renal disease is actually impaired. Patients with end-stage renal disease are those patients who are having kidney failure. Their kidneys failed, and they need treatment that will let them be obligated to attend that treatment 2 to 3 times weekly in something called a dialysis unit, where they will be spending about 3.5 to 4 hours in addition to transportation time from the dialysis center to their homes. And this is going to spend like 5 to 6 hours per day. If you can imagine 3 times a week, a person is going to a dialysis center, being connected to a machine for about 3.5 hours and wasting most of their days on that dialysis machine. This was proved in the literature that it did really impair their quality of life. There are many Western instruments that were used to measure the quality of life and health-related quality of life, and those instruments were validated to the Western community. However, within the Arabian world, especially in Saudi Arabia, there are no validated quality of life and instruments to assess and evaluate the quality of life of different patients with different diseases. The conceptualization of the concept within the Saudi context was lacking as well. Hence, this study was planned and it has had a major aim, which is to explore the meaning of the concept of health-related quality of life and its constituents as viewed by patients with end-stage renal disease undergoing haemodialysis, which is the dialysis treatment within the eastern region of Saudi Arabia. I just forgot to tell that some patients will be treated by kidney transplantation. Well, they will be having a new kidney to replace their failed kidney. And also the literature showed that those people do have a little impaired health-related quality of life because even they had a new kidney, they are still undergoing certain treatments and medications that will suppress their immunity in order not to get their kidney rejected after transplantation. So still they are better than the patients undergoing hemodialysis, but their kidney is still also impaired. However, their quality of life is still impaired. Going back to my study objectives, because I'm exploring the meaning of the concept, I'm going to define it, define the concept of health-related quality of life, determine its domains and indicators, and conceptualize it in a model that has relationship that shows the relationships between different domains. And this is particularly for people living in Saudi Arabia and undergoing hemodialysis. The methodology and methods that were undertaken, qualitative study was conducted in order to achieve the study aim and objectives. The sample was a sample with maximal variation. Patients who participated in the study were selected particularly to ensure that there is maximum variation in the sample. What I mean by that because I'm looking at this highly social concept, I was concerned about selecting patients from different social backgrounds, from different ethnic backgrounds, even within the Saudi community, because this big country and this kingdom of Saudi Arabia have got the east and west, south and north, different people. We've got Bedouins, we've got civilized people, we've got people living in the coast. And these different peoples have got different conceptualization and meaning of their quality of life. Hence, I used purpose of sampling in order to ensure that I'm getting the different views from different patients within the country. I'm not sure why is this. I'm aware of the slide, Jen.
Yeah, it looks like it went back to just the regular PowerPoint. Are you still controlling?
I guess, yes, I'm back.
Okay, yeah, go ahead and try. Maybe we pushed something wrong. Okay, yeah.
Okay, I'm back.
And then,
yes.
Okay.
Returning back to the sampling and recruitment, sampling continued until thematic saturation was achieved, because this is a qualitative study and we cannot have a predetermined sample size. And I ensured that thematic saturation was achieved throughout the sampling, and I reached to 22 participants. Data collection was I used in-depth, semi-structured interviews with the participants and using an interview topic guide. The interviews were conducted in Arabic language, and it was audio recorded. Moving to the data analysis. So in qualitative research, data analysis is quite different because we're not talking about numbers, we're talking about themes, categories. So at the beginning, there was some sort of data preparation where transcription took place. After that, a forward and backward translation. And this step was very essential because the interviews were conducted in Arabic language, and I wanted the study at the end to appear in English language. So I needed to translate it to English and backward translation into Arabic to ensure the validity of the translation and that we are not missing any term in between. The data analysis, as I said, thematic analysis was undertaken following Brown and Clark. And this included the steps of coding the transcripts, categorizing those codes, and ending up with themes development. Those themes defined the concept of quality of life and determined the key domains and its determinants. So let's move on to the findings and results of the study. The first aim, or the first objective of the study was to define the concept of health-related quality of life. Different people defined this concept from different perspectives. So one of the patients some of the patients talked about the concept of health-related quality of life in terms of the health status. So they defined quality of life as it is the time wherein their health will be improved and they will be relieved from all diseases and from all treatments that they are undergoing. Other patients defined it in terms of socialization and their ability to socialize with their relatives, with their friends, and other people in the community, because as I said, the dialysis treatment prohibits them from socializing because the dialysis the dialysis procedure is long, it wastes their daytime, and they get out of the dialysis center tired and weak, and they just go home and they rest. So some define the concept in terms of socialization and their ability to socialize with people. Others defined it in terms of the psychological well-being. So they looked at the quality of life as happiness and their ability to be happy and productive in their life. Some looked at it totally in terms of religion and their ability to perform religious obligations, such as fasting and praying, and some viewed the quality of life as their ability to perform those religious demands. Other people looked at it in terms of the quality of healthcare services that are provided to them. One patient looked at it in terms of like the opening the doors for them to get all the benefits from the healthcare services, such as the social services, psychological services in the hospital, and other healthcare services that could be provided. And he defined it in terms of the quality of healthcare services means the quality of life for us, people undergoing dialysis, because they are depending on the dialysis machine and they are depending on the dialysis center and the hospital, and they cannot be detached from it because of the disease. Other people looked at it in terms of financial income. And as we know, also one of the issues affecting the dialysis patients is that it affects their ability to work, and their financial income sometimes would be affected by the disease and its treatment. Another people looked at it in terms of the need satisfaction, and whatever their needs are, whatever their needs are, if they were satisfied, this patient will be having a good quality of life. regardless what are those needs, if they were health needs, if those needs were in terms of love and belongings, socialization, as I said earlier, psychological needs. If those needs were satisfied, patients believe that this is the optimum quality of life they can get. So at the end, after looking at all those aspects that patients determined in defining the concept of quality of life, I was able to put them all together and put one definition where I defined it as it is the personal satisfaction with health, social, psychological, and financial status, religious performance, and the healthcare services provided. So here I am taking all the aspects that patients looked at as a definition of health-related quality of life, and I proposed that definition. Moving on to the domains and indicators of health-related quality of life. So because this is a multidimensional concept, it needed many domains to define it. And looking at the literature, different authors had defined, or determined the domains that are important for the concept of quality of life. From that study, I was able to find that the concept of health-related quality of life had 5 important domains. These are the physiological domain, where we are looking at their physical ability, the other illnesses that the patient could be having besides the kidney failure, which is comorbidity, the complications of the disease, pain and comfort, sleep, sexuality, diet, and weight control, medications, and vascular access. The vascular access, which is, we can consider it as the key aspect of dialysis, because if that vascular access was damaged for whatever reason or impaired, the quality of dialysis will be affected, and patients as well will not get the benefit of the dialysis session that they took. So it was considered and determined by so many people, by so many patients who participated in this study, because they know that this vascular access is very important for their dialysis, and without it, they cannot perform a good dialysis. The second domain is the social domain, and as I mentioned, it's the key domain determinants or indicators are the social relationships, the social activities, playing the expected social role, such as a mother or a father within a family, and what is expected from them, and their ability to play that expected role, and the social support as well. So when we say social support, to what extent are patients receiving support from their relatives, from the near community or the close community, from their employers, from the country, from the government, from the healthcare system that we've got? So what type of support are people taking or receiving, those dialysis patients? The third domain was the psychological domain, and which was really centralized, as I will show you in the next slide. The psychological domain, it was indicators were about psychological well-being, satisfaction with life, feelings of low mood, and this is having low mood or depression even, or depressive symptoms is one of the complications that patients on hemodialysis will be having throughout their chronic illness. And anxiety and the fear of death. The body image disturbance was very, very obvious in this study, especially when it received from or found in female patients. Moving to the religious domain, which is one of the important domains that appeared, it had 2 indicators, which are the religious beliefs and their ability to perform religious worship. Because of the illness, sometimes they cannot fast, sometimes they cannot pray, and in a Muslim community, these things are very important to people. Religious beliefs, One interesting finding is some patients were accepting their illness and living with it because they believe that it provides them as a benefit within their, from their religious beliefs, and that they will be forgiven from any sins that they had in their previous life. So they accepted that illness and they were able to live with it and adapt to live with it. The last domain was the vocational domain, which is the ability to work, and this was one of the strongest findings that were found in male patients who were sometimes prohibited from working because of the illness, and the employer's support and the financial security of the person and the family as well. So the vocational domain was very important for patients on dialysis from this findings of this study. So moving to the conceptualization, as I said earlier, the psychological domain was centralized within that model, and all the other domains affected the psychological domain and psychological well-being and happiness and all this. And it eventually contributed to the health-related quality of life as a whole. The healthcare services, as you can see, was added as an external determinant, I would say. It was not considered as a domain because it is not a domain of quality of life. However, it affected strongly for patients undergoing hemodialysis and on the concept because the healthcare services, the better healthcare services provided to patients on hemodialysis, the better their physiological domain and health status will be, which will contribute eventually to the psychological domain and affecting the health-related quality of life at the end. As a conclusion, health-related quality of life concept has an individual meaning in Saudi Arabia. The domains in Saudi Arabia are similar to those in the Western countries. However, the determinants of each domain differed for patients on hemodialysis in this country. The conceptualization of health-related quality of life is unique in Saudi Arabia. And from that conclusion, we can find out and say that we need real valid tools that are culturally specific to assess the health-related quality of life needs, the health-related quality of life in Saudi Arabia. We need culture-specific instruments. We need cultural adaptation for existing instruments to make sure that we are really assessing the health-related quality of life of patients in Saudi Arabia. This will help us to determine the healthcare services needed for those patients and to identify also the needs of the patients on hemodialysis in this country and to provide those services for patients, and also to evaluate the quality of healthcare services that are provided. The individuality of the concept must be considered when assessing the quality of life of patients undergoing hemodialysis. It should not be neglected, and this could be achieved through having a culture-specific instrument to assess the health-related quality of life. I guess this was the end of my presentation, Jill. So I hope that my presentation was clear, and I'm happy to hear any questions or any additions from whoever was attending this presentation.
Excellent, thank you. Can you hear me?
Yeah, I can hear you very well.
Okay, good. Well, thank you so much for that presentation. Really interesting, particularly what you mentioned of how the tools measuring this must be specific to the cultural issues that you've recognized in Saudi Arabia. I just had a few questions to follow up. you said that there were Western instruments measuring health-related quality of life, and I wasn't clear on what those were. Did you explain what
For
those were?
example, yeah, for example, we've got the short form 36. It's one of the famous instruments in the Western community. But although it was translated and culturally adapted to Saudi Arabia, however, it didn't tackle the needs of patients on hemodialysis. There are other instruments for kidney failure itself and patients on hemodialysis itself. I cannot recall the names, but there are instruments. Those instruments were developed in Western community. So, for example, you will find an item there talking about, let me say, ability to exercise and jogging. In this country, in my country, it is too hot and people do not exercise outdoors. They exercise indoor. So such a question would not make sense to someone who will receive the question. So here are the very tiny things that could be there in a tool that could not give us a real valid finding at the end. So this was what I meant when I said Western, instruments, and so on, and so on. This is just
I see. And then when you said you had 22 participants, and I didn't hear, were they all receiving this treatment at the same facility?
Yes.
Okay.
Yes, it was one facility. But as I told you, I was interested. I made sure that I did take from different cultural backgrounds, such as interviewing, Bedouins, civilized people, villagers, but they are all receiving the treatment in the same place.
Okay. Yeah. And did they indicate their religion, or was that just something that was reflected when you asked the questions?
It was obvious from their responses.
Okay.
I had one Indian patient, by the way, and one Yemeni patient. I wasn't concerned about the nationality. I was mainly concerned about the cultural background and social status of the patient. The religion was not a question for me, but it appeared that they were all Muslims at the end. Even the
sure.
Indian patient, he was a Muslim. Yeah.
Were there different responses, given that they were, you said all Muslim, were there different responses, or were they, you mentioned even that some of them had mentioned they felt forgiven from sin.
Yes.
Did they report a higher quality of life because of that, or because of their religious viewpoint?
Actually, no. They reported a better quality of life if they accepted their illness. And they accepted their illness because they believed that having an illness would relieve their sins at the afterlife. So this was the way they conceptualized it. It's not that they had a better quality of life because they had an illness. No. Actually, it was the other way around. They did say that our quality of life is impaired because of that illness. But what helped them to adapt and live with that illness is their religious beliefs.
I see. Okay.
Yeah,
and do you think that that's certainly something that must be considered if you developed your own tool for an ISQOL tool for those in Saudi Arabia?
To be honest, I wouldn't, let me tell you how, let me try to rephrase this. The first thing, I'm not looking at developing a tool from scratch. Okay. There are lots of health-related quality of life tools in the literature. And in order to do some cultural comparison among studies all around the world, we need to have similarity in the tools. So I'm looking more at adaptation of an existing tool. For example, the WHO quality of life tool. It's one of the generic tools. However, it has a part or a section about the spiritual domain, isn't it? So when I look at that spiritual domain, I will try to adapt it to be fulfilling or satisfying the perception of Muslims who are part of this study based on the findings of that study.
I see.
Yeah. Yeah.
And is
And
that your, do you feel like that's your next
yes.
step, is to adapt a tool?
Yes, actually, this study, the study that I presented is part of a mixed methods study that was planned at the very early beginning. The mixed methods study had the first strand, which is the qualitative part, which defined the concept. And the second section will be adapting an existing tool. The third section will be validating that tool that had been adapted. And I'm really looking at adaptation, not, I'm not planning for developing a new tool from scratch.
I see.
Yeah.
What's your timeline on that? Do you feel like that would be a couple years, or?
Perhaps it's going to take, let's say, 2 years from now. 2
Okay.
years.
Good. So hopefully you can come to our conference in 2 years and present a follow-up to this study.
Yeah, sure. It was an interesting conference, actually. You know, networking with other researchers from all around the world. It was one of the interesting experiences.
Oh, good, good. Well, were there any questions that you received during your presentation?
Yeah, I had quite questions. Do you want me to tell about them?
Sure, I'd love to hear them.
Yeah, one of the questions that I received was about considering the sexual determinant as part of the physiological domain. And the person who asked this question was considering it as part of the psychological domain. And my response was, she said, how did you determine that the sexual domain, sexuality was part of the physiological domain? Why didn't you add it to the psychological domain? So I told her that I did, for that reason, for that sexuality itself, I did look at the literature, and I found that it goes in more than one domain. It can go to the social domain, and it can be a part of the psychological domain as well. Why did I put it in the physiological domain? Because this is health-related quality of life, and I'm looking at the quality of life of patients with renal failure, with undergoing hemodialysis, and because the illness affects the sexuality of patients. And it was one of the issues that they mentioned within the interviews. So I did decide that it should be, or I would not say it should be, I viewed it more to be fitting within the physiological domain.
I see.
Yeah, this was one of the questions. The other question was about, they didn't know that it's a mixed methods study, and this is the first strand. So they did really ask about the 22 participants and how can we generalize those findings. So then I told them, well, this is a part of a mixed methods study, and we are looking for generalizing it by conducting quantitative study at the end after adapting an existing tool.
I see.
Yeah.
Good.
Yes.
Well, I think this was a great presentation, and I am looking forward to seeing the results after you've created an adaptive tool, and hopefully we'll be able to have you back to present your research after you've adapted the tool, and even further beyond that. So
I hope so as well, and I'll be more than happy to present whatever findings I get in future conferences with ISQOLS.
Excellent. Well, thank you, Dr. Algarni, for this wonderful presentation, and we look forward to hearing more from you.
Thank you very much, Jill, and I appreciate your support in this. Looking forward to attend again and participate with you on future webinars as well.
Wonderful. Okay, now I will stop recording.